I'm serious. I go out, like, am I after lunch and people are hanging out, I just, come on, get your butts in here. I'm not, so. Okay.
All right, let's, all right, we're back. Let's please put our hands together to Dr. Kevin Boyd. Welcome.
Thank you.
Just have a short intro, if I may. Dr. Kevin Boyd is a distinguished pediatric dentist. Let me get rid of the timer here blocking the bio. It's still here. There we go. An educator, renowned for his expertise in performing risk assessment, diagnosing and treating very young children who present with self-correcting malocclusions.
Non-self-correcting. Non-self-correcting.
Better get my act together. With non-self-correcting malocclusions with possibly associated sleep and breathing difficulties. I need to do the speaking exercises. He lectures worldwide on the topics of early childhood malocclusions, under 72 months, pediatric sleep, breathing, hygiene, and the newly emerging healthcare discipline of evolutionary oral medicine, also often called Darwinian dentistry. It's cool. He's married and has two, I'm sure, amazing adult daughters. When not working, he enjoys tennis, skiing, and sailing. Please welcome Dr. Boyd again.
Thanks. I'm going to get right to it because I don't think how much time do I have? 2 hours. 2 hours, he said. I heard it. That's okay. All right, so lifespan is life expectancy, how long you're expected to live from birth. Has anyone yet heard of Healthspan? Healthspan. Peter Attia, Outlive, write it down, great book. Talks about Healthspan. Okay, Simon showed the marshmallow test, and I was like, I'm not going to talk about this, but it's a big part of my thesis. Even before I read Attia's book, I was reading about that. You people, and all of you, even if you don't treat, not everyone, you're not obligated to treat a 3-year-old. Give me a break. It's not for everybody. But you are, it's incumbent upon you, because of the American Dental Association, if nothing else, that you assess risk. Validated, is that my heartbeat? I'm not even nervous. What is that? Oh my God, I thought I'm exposed, So anyway, where was I? So you need to risk assess. Validated risk assessment for sleep and breathing disorders in children and adults, but we're about kids here. So in treating, only if you want. And don't be scared. Try it out on your own kid. So you're not going to hurt anybody, okay? And then you'll get better at it, and you'll be able to, I can't do that, Simon told me. You will get the confidence that he has, that Amanda has when she listen to her. She's like, you guys, any kid can do it. Well, they can do it in her hands. She's an orthodontist that doesn't have pediatric dentistry behavior guidance training, but it's instinctual. Mariana Evans is the same way. Orthos don't get this training. Pediatric dentists do. And we have to do it for giving shots and doing pulpotomies and pulling teeth. This is a piece of cake, getting a kid to sit still for a scan, or it's just not hard. It will be at first, and you'll be able to do it with confidence. So what I'd like to now talk about is you can, in your consultations, you can say to parents, adult caregivers, okay, guess what? If we get through this and we can resolve these structural issues and functional issues that your kid has at an early age, they will live longer. There's evidence to suggest, barring unforeseen circumstances, that children will have a longer lifespan. They'll live to be 100 at least. And guess what else? They're going to delay getting sick till they're 99. Okay, they stave off chronic disease. That's called Healthspan. Right now, lifespan in the U.S. is about 78 or 79 years old. It goes back and forth because of COVID. And the Healthspan is somewhere in the early 60s, late 50s. meaning you got crappy life after 54, 55, whatever it is. Kids who establish, thank you, Simon, as evidenced by the marshmallow test, but there's before the marshmallow test in 1973 in Dunedin, New Zealand, there's a hospital there, and they had money to study kids for 5 years. All the kids born in 1972 and 73 in that same hospital had money funded by the U.S. National Institute of Health, believe it or not. I don't know how they pulled that one off. But, and then they kept getting money, and they tested all these metrics, and one was self-control before the marshmallow test. How long could a little kid stand on one leg at 2.5, 3 years old? They had all these, and the kids by age 12 who had established by validated metrics that they had good impulse control, guess what happened? They are more resistant to chronic disease. They manage wealth better. They are less likely to become criminal behavior, and addictive behavior. And I'm going to show you a visual of something else that happens. Now, Frederick Douglass, look at that. It said broken men. All right, that was 19th century language. So I updated it for you guys. All right, men and women. Half the population is left out of that. So I'm not going to show you that because Simon did. But here's the Healthspan and lifespan data that I like to show people. This is Google this, you guys. This is one of the most robust longitudinal studies in the world. And there's so many publications that come out of it. Has anyone heard of it here? Like, I hadn't heard of it. They got a publicity problem. But here's what happens, right? I mean, more resistant to chronic disease, better impulse control, better wealth management, and everything, addictive behaviors and criminal behaviors. But guess what else? Hello? These kids were nose breathers, okay? They almost had to have been. They didn't do orthodontic data. They didn't start ortho till 12. And they said that what they gleaned from the data is that deciduous malocclusion is 100% resistant to self-correction. It will persist. But guess what the beauty of that data is? You can prepare parents to save up their money for braces. Isn't that a wonderful service you can do for people? Your kid, 100%, their malocclusion is going to persist, so you can get prepared for it. That's what they came up with, these authors from the Dunedin study. It's sad. So anyway, they look younger. Okay, can't remember the slide. I've changed things so much, but it was slide number 40 or something. It's what I spent 8 hours on. And I started developing it 3 weeks ago, this concept. I put something together over the last 12 years since I've been dabbling in anthropology. I'm not an anthropologist. I'm a wannabe, okay? But I've done a lot of research. I don't have a PhD, but I'm a visiting scholar at Penn and now an adjunct at Arkansas in the Department of Anthropology. But something happened between 2 million and 1.5 million years ago to our ancestors that became us, okay? Our genome is, well, I'm not going to give it away because that's one of my little questions I show. But that's Homo erectus, okay? And that person led to us. Okay, we're on that line, that clade they call it. I'm going to give you a little anthropology training. It's ridiculous that we don't know this stuff. I was always nervous when I got up. I thought everyone's going to know this but me. And I know enough to be dangerous, but I know way more than most of you guys do. And unless you've been hanging out with me, because we talk about it a lot. Has anyone had any anthropology degree training? There was one anthropologist that I met at dinner last night. But it's too bad, because it should be there. It's like an engineer not having to know physics, a healthcare professional not having to understand how natural selection works. So I'm going to give you some tools, okay? So listen to this. Oh, no sound. I need to have sound here. Mythology, orthodontics.
There are no diseases associated with malocclusion at all. None.
Did you hear that? That's a word that starts with bull, has an S in the middle, and it's not bullseye, okay? And this is in Mike Muse, Open Wide. That's Peter Big. He is a legend in orthodontics. When I was training at Iowa, he and his wife, Catherine, they were all that. They're brilliant, both of them. But he is starting to believe some things that just are not validated. He used the wrong word. They're not causatively, they haven't been shown causatively associated, but they are comorbidly associated. And that's what I'd like all of you to start using. So that is just not true. And I can just show a few slides. Simon is so good at validating and backing up everything that he's saying with literature. But, this has been known right away. This just disproves his hypothesis, what he was saying. Absolutely none. What he should have said is, I have a hypothesis. He doesn't. He says this is fact. And they're legends. Some of these people, they're heroes. And throughout Greek mythology, heroes were people that started out as very respected people, but started to believe their own hypotheses without any evidence. And Plato, Socrates, all those guys, at least some of the stuff they believed. But there was a lot of stuff, and like Peter Vig, he's a really smart guy. I'm introducing something called the stoplight. And when you see red, you think vertical, and Simon covered that, and Peter Bouchang is one of the world experts on it, a real scientist. If you see green, that's complexity, the least complex. The least complex dimension to optimize at a young age is the transverse, and it's almost ubiquitous in all malocclusions. Okay, and it isn't taught to us that way, but it's true, and I think most people here would agree. If you've got a vertical problem, if you've got a sagittal problem, you've got a transverse problem, okay? So, bony nasopharynx. Has anyone ever heard of the bony nasopharynx? Okay? It is the distance between the posterior nasal spine and the front of foramen magnum called basion, okay? That is the bony nasopharynx. And that changes. I'll give you a hint that the foramen magnum does not move, okay? It stays in the same place. So what's moving? What must be moving? The posterior nasal spine and a point when you transverse expand. Depending on the myofunction, degree of restriction of the tongue, if there is that, but it's still going to move forward. Almost always, and a lot. If you put a face mask on, if the kid has good masticatory competence, new word that I'd like to introduce into the lexicon, this is the bony nasopharynx. So what it is, if you go from basion to posterior nasal spine, and then you draw a perpendicular that's created from here to here, there's a superior adenoid and an inferior. They're all affected by transverse expansion alone. And if you put in sagittal, it also, if it's narrow, it correlates with high risk for excess vertical, lower facial height compared to total facial height. I won't go into all that, but I've been measuring this since I've had a cone beam, over 15 years that I've been measuring this. And you could see the adenoid, and this is where they measure it. And the adenoid doesn't necessarily have to be huge. It's its proximity to the soft palate. That's what causes the problem, and that's what Linda Aronson, an orthodontist from Sweden, discovered in the 70s. The Swedish National Health Service was going broke from all these kids that are getting their adenoids out just because they were large. There were certain kids that didn't go through with the surgery, and they got better anyway. So what's going on? And that's what Linda Aronson found out. It's not the size of the adenoid, but the size of the box that it lives in. Okay, so this is unequivocal at this point, is that their malocclusion is a comorbidity with sleep-related breathing disorder. If you've got malocclusion in early childhood, and early childhood is defined by under 72 months old by the Academy of Pediatric Dentistry because of caries, okay, and is it severe or not? And that's another qualification of it. But if there's a malocclusion, there is either undetected sleep-related breathing disorder behavior, not necessarily full-blown apnea, that's the worst case scenario of sleep-disordered breathing, all right, or there will be. It's reliably predictable, but this person is going to have difficulty with breathing through the nose, primarily. So, and that's a hypothesis, but it's highly supported, and that's all I'll say. I'm not going to show all the studies. I think Simon did a really good job of saying that those of us in this realm of teaching this, Amanda, me, and so many others that are doing this now, we know that there's evidence to support this. So there it is. Now, that last thing that right there, okay, so there's the adenoid 1 and adenoid 2, okay, from the soft palate. But look at this. This line from posterior nasal spine to basion, it gets longer, and it will get longer with age unless there's some real problem. And I'm measuring these on the Bolton templates that I have, and I'll show them to people if anyone wants to look at them, of what they would just, with growth in a good growing person, okay? But it gets even bigger with expansion, with good posture, good tongue posture, lip seal, and a reverse pull face mask. I throw a reverse pull face mask on class 1s, 2s, and 3s, and probably over half my patients will get one because I can measure it on the self that the maxilla is not where it should be, or maybe it's imperceptible, and they have a resistant symptom like bedwetting. I put a face mask on that kid, and I tell that parent in front of the kid, guess what? I've got so many kids that their bedwetting stops when they start wearing this. Now, I do, but is it because I suggested it? Do it in front of the kid, and some of them are probably solving their own problem. I'm not really seeing that maxilla coming forward, but I see mitigation of persistent symptoms all the time just by this face mask. Put it on, we call it a dream mask. I got that from Lauren Ballinger, a pediatric dentist in Massachusetts, who I do a lot of work with. She calls it a dream mask because they dream better. They spend more time in REM sleep. Guess what? They do. Okay, I don't do a polysomnograph on every kid, but they always report that they sleep better. So I don't know. I don't know the reason for that. I can't really give the science behind it. But this is a typical example of what I see. Now, do you think an ENT might marginalize me because I am interested in conjunction with the PCP, with the primary care pediatrician, right? I don't refer to specialists by myself. I don't involve that PCP, okay? And that's one way to get yourself known. He does more than fill cavities. He does that too, not very much anymore. Okay, but most people don't know that this is in the oral health realm. We're using that I'm on a task force at the ADA now. We're trying to get the name changed from dental health to oral health. All right, dental health implies teeth, but it's everything above the neck. It's a shared domain with other disciplines in healthcare. Okay, so this is something that I can engage in ENT, and I've been invited to 3 ENT departments to give this lecture to teach this metric. This is not something that is well known to ENTs. And the ones that are starting to get aboard, and we've got a couple of them in Chicago now, and I've been trying for years, they're even referring patients to us for adjunctive expansion. If not sole, let's not do the adenoids until Boyd expands them. That's what they say to them. So this is pretty impressive. Okay, so if RPE is the solution to the problem, okay, quality of life, general health, okay, what must be the pre-treatment skeletal diagnosis? Transverse deficiency, with or without a crossbite. I don't think anyone needs convincing on that. And you showed the BU study, and there's a guy, orthodontist named Sean Carlson in San Francisco. Has anyone heard of him? He's brilliant. And Harvard trained, and he's the one who took that paper and said this is a brilliant paper. Who needs a crossbite? There's other ways to validate that metric. Well, one of them is behavior, that does improve. You can take that to the bank. That's a very powerful reference. So Audrey Yoon she's a dual-boarded orthopedo at Stanford, and she is, and her, Rebecca Bacow and some other people, they've got a great team there, but they're talking about the different stages, but we should be getting in very early. I don't think this is new. It's definitely not new to anyone in this room based on today. I also, with Dr. Stephen Sheldon he's a neurologist, pediatric neurologist at Lurie Children's Hospital in Chicago, and sort of picked me out of a crowd and said, I'm going to train you and a couple other dentists because these damn pediatricians are not spending any time assessing sleep and breathing health in their patients. And so he trained us at St. Louis University in sleep medicine assessment, and pretty much this is something that everybody should be doing if they're not. We came up with this, ENT Rustin is his last name, did this medical illustration. We call it the craniofacial respiratory complex. I'd rather people never said the word craniofacial again, because it's connected to the respiratory complex. It really is. Or who can tell me what the CDC stands for? Shout it out. Center for Disease Control and Prevention. Everyone leaves that out. Okay? So craniofacial respiratory complex. That's what I like. Okay, so we're going to talk about ontogeny, and that's what happens in a single generation, ontogenetic. Okay, now, hypothesis that a distal step primary molar relationship sometimes becomes a class 2. Does anyone buy that? Okay, that statement's wrong. It's always going to be a class 2. That's supported in the literature going back about 70 years. Okay? You will never see a distal class unless it's from a missing tooth or something, but no, it will always become a skeletal class 2 if you don't treat it. Myopia. Nearsighted this. It can lead to macular degeneration, retinal detachment, all kinds of problems. Why would you wait for a stage 1 disease to turn into a stage 3 or 4 disease before you treat it? Well, because then, Medicare will pay for it. That really is some of the crap that's going on. This malocclusion appearing in the deciduous dentition and not self-correcting has been known for over 100 years. Okay, it's been known for 100 years, yet it's still okay. And I'm so glad Amanda indicted her own profession that way, because that's just the way it works, and people will defend it to the death. Look at this from 1921. Is that evidence-based research? It is. The reason I asked Simon, will you please define evidence-based research? Because I know that a lot of you have been pounded. Show me meaning randomized, blinded, prospective randomized trial that costs millions of dollars. It's the least available evidence. It's robust. It is. It's the most robust form of evidence. But you can't withhold a known therapeutic regimen for the purposes of creating a control group. There's a reason for that. I'm going to show you why you can't do that. It's unethical to do that. You will never find research to support in that kind of research to support what Simon and I and Amanda and other people are talking about. Okay, so here's the transverse green light, least complex. Don't say easy. It's the least complex to optimize at a young age. It's an age-related algorithm. I call it the Bogue index, and I'm going to discuss that further. Some of you have heard me talk about it. Sagittal is more complex, not quite as easy, but you can control it and you can guide it. It can get, in fact, Vivos does, they call them guides, and there's things you can do to really help it improve, okay? Some people are doing more than others. And this is the red light, and Simon killed it, This is the most complex problem that there is, and it needs to be recognized early. Guess what is very difficult to recognize early in the deciduous dentition if you don't have an x-ray? Vertical growth. And now I've done my own little, test on this cohort with some experts and showed them pictures. I've got lots of them of children. I have cone beams on kids from 2 to 5 years old. I've got hundreds of them. Okay, I did the radiation in an ICAT flex, 7 microsieverts for a quick scan. Okay, 7 microsieverts. That's 2 days of outdoor background radiation, being outside, for a couple days. A standard Panorex, 7 microsieverts. So the kids got to sit still for 4.5 seconds. Guess what? And I love the way Amanda said, you know what, you can do it. And that kid will open. She knows they will. But you may not until you start trying it and you see that if you got the parent on your side, you own that kid, okay? If you don't have the parent on, or one parent doesn't, I didn't get braces till I was 13, that's the dad. We're not ready to treat because Billy heard you, and sorry, You don't think he can do it, so he won't do it. Maybe not right away. Okay, Tim Bromage. Has anyone heard of him? Dental anthropologist, NYU. Well, I wrote to him, and Robert Corricini wrote the textbook on malocclusion and anthropology. Okay, I wrote to both of them because I came up with a hypothesis: is that how could that 35-year-old who died 5,000 years ago have that structure if he wasn't perfect in the deciduous dentition before he was 6? Is that a supportable hypothesis? And both of them said, yes, it's reasonable. He said, well, you can only go back 20,000 years because we don't have enough skulls from, okay, that'll work. Let's go back 20,000 years. But yeah, so that's a supportable hypothesis that a child, and I turned it into this. If a child did not have, that looks like Simon's posture, breathing through the nose, nursed and weaned for up to 3 to 4 years, on demand for the first 6 months, chewing everything that everyone in the tribe was chewing by 12 to 14 months old, because that's in the fossil record, and they can radiometric date it of when kids stopped breastfeeding and the food that they were eating was the same as their parents. If they didn't have that, they died. We don't see malocclusion, really skeletal malocclusion of appreciable dimension at any age, up until about 400 or 500 years ago. And even then, you see maybe Egyptian mummies with a little incisor crowding or something. Those were the rich people that got mummified, right? But you don't see, even stillbirths. They didn't have ultrasounds, obviously, but that's like a stillbirth is like a prehistoric stillbirth is like an ultrasound. You don't see malocclusion anywhere. And the reason is a child, if they had antecedents to malocclusion, meaning myofunctional disorders, bad posture, whatever, they didn't live long enough to develop malocclusion. So you just don't see it, all right? They might have, mom couldn't breastfeed anymore. There wasn't another lactating allo mother in the tribe, infection, predation, but the kids died, but there's not malocclusion in little babies or kids. Okay, so this is what we see in the fossil record. In a wide choana, and these are skulls from the Penn Museum that we can't really do much with anymore. There's all kinds of rule changes and everything and since the pandemic. But Mariana Evans and I looked at lots of them. We took cone beams. We were able to take them out of the museum. We compare them to the Bolton norms. They're very, is everyone familiar with the Bolton norms? It's a cohort. The first cephalometric machine was at Case Western Reserve in Cleveland, and they petitioned kids throughout the Cleveland area that were well-bred. They didn't have to be wealthy, but they were nursed and weaned, and they ate fresh food. And there's lots of criteria. We don't know all the inclusion criteria in it, but Buzz Barents, who used to be editor of the AAO journal, he did a paper on it and talked about some of the inclusion criteria. But the Bolton, I have all the templates. I have the frontal cephs and I have the lateral cephs from birth to 18 years old. Paul Newman, the actor, was in that cohort. What they wanted was a live cohort of kids that were healthy. Most dry skulls were dead people that were sick. So they didn't have really good skeletal norms until this cohort. And they really were beautiful or perfect. That metric between the posterior nasal spine and basion, I'm measuring those now on all of the cephs from the Bolton norm to see what happens just with age, with growth, okay, and then how much we can change it with treatment. So this was done by a reporter from The Atlantic magazine. She followed us for over a year. Me and Mariana Evans and a lot of other people are mentioned in this. But it just talks about what has happened over the 300,000. Oh, I gave it away. That was going to be one of my test questions. But we've been around a long time. So anyway, that's phylogeny. And boy, what is the matter with me? Okay, so y'all got it, right? That's it. That's how, when I started this journey, it wasn't even sure that it was at least 100,000 years that our genome hasn't changed. So there hasn't been macrogenomic change in 300,000 years. There's been microgenomic change, which means, epigenetic, and, like the ability to metabolize lactose. That's rare. The wild type is lactose intolerant. All right, so there's been micro changes, but not macro. Light skin. We're all African, and we are. Everybody here is of African origin. We all descend from the same African great several times. It would take you 3 months saying great 24/7 to how many greats it is. But she lived 150,000 years ago about in Africa. So everybody, every woman and every man with mitochondrial DNA, it comes from her. They call him evolutionary Adam, the father. All men have on their Y chromosome a gene that identifies with one man that came from Africa about 70,000 years ago. So this is true. You can't argue with the DNA. It's absolutely true. There's so much evidence to support this, but it's very difficult for some people. And it just try to find a way to be comfortable with this, because it really will help you understand a lot. Okay, so this is a paper that I published with Lucia Pasquet. She's a speech pathologist from UCLA, and she's from Italy. And her parents owned a monastery that was over 200 years old outside of Venice. And they found some skulls when they were redoing the kitchen in the main house. So I got to analyze the skulls. I got permission from the Italian government. So that went into my database. This just talks about how our faces have gotten smaller, okay? But we didn't necessarily have malocclusion. So our faces have been getting smaller for how long? About 2 million years, 1.5 anyway. And what happened at 1.5 million years with Homo erectus, the leading hypothesis, but this is phylogeny. Anything that happens on our line over successive generations, or from your great-grandparents to your grandparents to you, that's phylogeny. That's over several generations if you get changes in traits. Ontogeny is just what happens in one generation. We're suggesting now, and this goes back in the literature 100 years, that class 2 malocclusion anyway probably has its origins in utero. It seems to be a modern industrialized phenomenon, because even stillbirths before 300 or 400 years ago, we just don't see babies with retrognathic mandibles. So there must be something going on. And it's not necessarily just the mother. Okay, men have to take care of their sperm before they conceive too. So any of you or your daughters or whatever, make them stop drinking and smoking, whatever, for at least 6 months before they give birth. Because their sperm can affect what can happen in subsequent generations. Women get blamed for everything. That's where all the organelles are and everything. All we do is give some DNA. But that DNA has to be perfect, and things can change epigenetically. So I'm the father of 2 daughters, so you can kind of maybe understand my passion. Okay, so these are 6 million years ago. That's the common ancestor with humans. Okay, they split about 6 million years ago. So one line or clade that leads to the chimpanzees you see in zoos doesn't look anything like whatever that common ancestor was 6 million years ago. Okay, but the other led to us. Now, Homo ergaster, he was called, and Homo habilis, the tool maker, over 2-3 million years ago, they led to erectus. And erectus split off to heidelbergensis, who turned into Neanderthals, and one went our way. So Neanderthals are our cousins, but they're not on a direct line to us. But their brains are as big as ours were. Okay, so fully human, 300,000 years ago. Has anyone heard of delightfully human? Okay, so that's... I just couldn't wait to do that. So industry is what brought about malocclusion, okay? It just coincides. What is it about industry? All life on Earth has 2 common factors. Now, life started on Earth 4 billion years ago. Take it to the bank, it's true. archaea, they were before, they're prokaryotes, that they're before bacteria, that led to bacteria that led to eukaryotes, which is what we are. Okay, but what are the two things that everything that's alive has in common? And this is why viruses aren't considered alive. Okay, they can make their own energy. They have a Krebs cycle, and they have nucleic acid, RNA or DNA. Everything alive, and that relates us to Luca, the last universal common ancestor. You can read about some of this. This was just published. It's in a myofunctional textbook. I don't even know if it's out yet, but I know it's been accepted for publication, and it's on a page and a half. So anything you guys want, I was asked this morning, do you have any handouts? And I was like, I sent a few things, but I don't think they got here. So, but I've got anything you see here, I have either links to papers or I have the PDFs. So, available versus expected evidence, okay, pre-World War II, and informed. And something happened in World War II. A lot of the literature just kind of, disappeared on these protocols that Simon and I and Amanda and other people are using. It's been around for over 100 years. This is not new. We rediscovered something. And then Evo-Devo is evolutionary developmental biology. Is sort of a new topic in anthropology. So does anyone know why I put that there? This is the reason we have Institutional Review Board. It's based on what happened here. What the Nazis did to humans is just abhorrent, what they did, and to make sure that never happened again. So we can't do anything, even on skulls, even on x-rays. I mean, if you're working with, you've got to go through IRB, and you can get IRB exempt if it's a non-live person, but you still have to do it. If you're working with live people, you cannot withhold a therapeutic treatment for the purpose of creating a control group. Cannot do it. Some of this stuff, it should never get through IRB. I've seen some trials, like, how did they get that through? And it's mainly in the orthodontic literature, okay? So anyway, look at this. Is this evidence-based? Do you have a problem with it because it's 1912, 1909, 1913? Look at this. Persistent mouth breathing following adenoidectomies. You know what that Dr. Bodsky, whatever, I can't pronounce his name, but physicians were writing about this. Find yourself a good dentist who can spread the deciduous arch, okay? And watch what happens to that breathing. When these kids start to have symptoms after TNA surgery, spread the arch, spread the deciduous arch. That's what they called it. E.A. Bogue, MD, DDS, I think he went to dental school after medical school. And this was in the late 80s. He said he spread his first deciduous arch 6 years after the last bullet was fired in the Civil War. And he had an office in Paris, an office in London, Chicago, New York, and Boston. Published, and I heard somebody talk about I think, Simon, you were talking about the NEJM. It used to be called the Boston Medical and Surgical Journal. Persistent mouth breathing following adenoid, enlargement of sinuses in young children by orthodontia, the relief of nasal obstruction by orthodontia. That's evidence. That is available evidence, okay? It's not of a prospective randomized trial because there was no such thing until after World War II. No such thing. So this is Loria Nahadas. She's a pediatric dentist extraordinaire in Dallas, and we just did 4 TED Talks. We made up this format to talk about 4 different things at the AAPMD meeting in Reno, Nevada last week. And a lot of the stuff you're seeing here, I just, moved things around a little bit and took, what went over well there. So this is how we came up with early childhood malocclusion. It's not yet in the ICD-10, International Classification of Disease, but we are really hoping that it will enter it just like it did for dental caries. And this was to get anesthesia costs frayed. There's a lot of kids who have to go to the operating room to get their cavities fixed. Disgusting. It's a total preventable disease, but big bucks, and it's really. I tend to bring up a story about in Chicago we have lots of potholes because of our hard winters and all that. And the Chicago Pothole Fillers Brotherhood, They were offered to test this new asphalt that was resistant to potholes. They turned it down. How come? Why do you think? Yeah, why? They'd be out of a job, right? See any parallel to our profession? Okay, I made that up about but there is no pothole. But I love to tell that story because nobody disagrees with me. Who wants decay to go away? That's why the Academy of Pediatric Dentistry in 2012 accepted a $1 million unrestricted grant from whom? Coca-Cola, you bet. Yep, a dirty little secret there. So anyway, and then there's early childhood malocclusion. That just means one cavity before the age of 72 months old, under 6 years old. If it's more than one, or in a kid under 3, they call it severe. Okay, so what is early childhood malocclusion? A sagittal, vertical, or transverse problem before the age of 72 months. And when is it severe? If it's comorbid with a sleep and breathing problem. We made that up, but why not? I mean, you can make up, look at all the myths that we believe nowadays. You can make up your own. Why not? You know, so this is supported. So anyway, can it self-correct? Rarely, I say, that's a hypothesis, but supported. What causes it? Nature, nurture, epigenetics. Simon covered that beautifully. Why should we care? That's why we should care, okay? And that's Steve Sheldon, pediatric neurologist at Children's, it used to be Children's Memorial Hospital. And I sat next to him at a faculty meeting one day, and he said, "Oh, I understand you expand 3-year-olds. Come on up to my office." Next thing I know, 15 years later, we're publishing together. He's getting me, you know, places to lecture all over the world. So why should we care, and what might present, excuse me, as obstacles? Behavior, okay? If you have a child in your chair and doesn't have a known syndrome, but they have malocclusion, are they a special needs patient? They are. They're a special needs patient. And, you know, Amanda knows how to handle them. I know how to handle them. I'm a pediatric dentist. Raise your hand if you're a pediatric dentist. Okay, so you are trained didactically and by clinical training experience. You know how to manage anxiety. How many of you are parents? Raise your hands. Guess what? You can be retrofitted to do this, okay? This is not rocket science. It just isn't. It's not that hard. But once you get over your fear, orthodontists, they don't want to get over their fear, most of them. They don't. They just don't want to get over that fear because they're doing well not having to do that. Thanks, Simon. So, and mythology gets in the way. So behavior, this is the main thing that people just balk at. I even had somebody today who wants me to help with their kid, and I think she's a pediatric dentist. And, you know, well, what if he won't open his mouth? I don't give a shit. You know, I mean, I'm sorry, this is being recorded. So you can block that out. But I just, if you got the parent on your side, I mean, what if a parent said to you, you know what, my 3-year-old just, no matter how much traffic's coming, if that light's red, he just wants to go. I can't do anything about that. Well, you know, of course you can, you know, and you do. They're not seeing this as anything that serious of what the long, because it doesn't happen right away. Or sometimes it is. They're already having problems. They don't see the relationship. Does anyone know who this guy is? That's Christian Guilleminault. All right, and he is the pediatrician sleep medicine specialist at Stanford who discovered that children can get this adult disease. In 1976, he published in the journal Pediatrics, kids can get sleep apnea. And he said, and I took this picture. There's like 300 people in Chicago. You've heard me say this. He's like, he looked at me. Dr. Kevin Boyd is taking my picture here. That's my trying to be a French accent, right? And I really thought he was going to get rid of me. I just thought, I'm out of here. I was just ready to get escorted out. And he said, I have to use the S word again, he is the only one who seems to give a shit about this. And he found this in the French literature, that this angle, and I was doing that, and Mark Moeller told him about me, so now I am a peer reviewer for the journal Sleep, because of him. So anyway, that was a big deal for me. Does it self-correct? Okay, why did I put the Nuremberg trials up there? Because this happened in 1944, I think, and it was before the Nuremberg trials. But they withheld treatment in kids, and they found out that deep bite persists, and crowding persists, and class 2 persists from 3 to 10 years old. Can't do that anymore. All right, so here's Heidelbergensis. This is the one who went from erectus to the Neanderthals and to us. So brain like 1,300 cc's, or maybe 1,450. Neanderthals are 500. All right, so facial size reduction, facial retraction, key defining traits of modern humans. Okay, this is the biggie that I am going to share with you guys, is that, here's a cause of lessened pronathism. This was written in 1881. Look at that. Is that why our jaws, well, they didn't mean pathologically. They mean, why did our faces get more inwards relative to Homo heidelbergensis or Homo erectus? But it still wasn't, there was no crowding. There was no crowding. Even though the jaw transverse, they got narrower. All right? Guess what else got smaller? Okay? Our gut size, our gut length started along with tooth size, jaw size, facial muscle robusticity. All those things got smaller, inversely proportional to what? Our brains. Our brains got huge. We had brains not much bigger than a chimpanzee up until about 2 million years ago. Something happened 2 million years ago. Okay? Phylogeny, new term. So this is, what can happen in a single generation. I learned how to do this the same place Simon did with Bill Hang. This was an overt class 3, but non-syndromic. There was nothing wrong. In fact, her mandible was a little retrusive when I put the Bolton norm on it. So that's what happens in one generation. So this relates to the first question. Do you see that, how baby food was advertised? For infants and invalids. Babies don't need to chew, right? It's too much for them, and their little GI tracts can't handle it. And we should flavor it with salt and sugar, okay? That's what goes into your baby food. This stuff should be outlawed, okay? But the way our system is, another good book, Ultra Processed People, all right, by Chris Van Tulliken. He's an identical twin. He and his brother, pediatrician, they do experiments on themselves. But he lectures widely about this. But look at that. I mean, that is a huge, put it in your office. I mean, take a picture of it, or you're going to get the slides, I guess. But for infants, and well adapted for children and invalids. Look at that. So here's Dr. Van Tulliken.
We have very, very good evidence that there is more than just fat, salt, sugar, and fiber that is mediating these harmful effects. Processing is important. And that this is a revolutionary way of thinking about food should, I think, surprise all of you. Perhaps the best example of why processing is important was an experiment done in the 70s by a group in Bristol. It was a very simple experiment. They got some apples and they left them unprocessed, and they chopped them into chunks, and then they pureed them, and then they pureed them and squashed the fiber out. And they looked at the effects of the nutrient, and they did it all immediately before participants drank or ate them. So even when we have a pureed whole apple, it's very, very different to eating the whole apple, to dismantling the apple with your teeth. Eating, the act of chewing, of manipulating food with your tongue, causes all sorts of internal physiological changes that are really, really important.
So, isn't that great? It's getting out into the ether now. These guys are great, the Van Tullikens. Okay, so here's my red light, green light, yellow light system that I developed with Airway Health Solutions Group. Ben Moralia, most of you have heard his name. I'm the preschool teacher at AHS now. Ben doesn't do that part of it. He takes them over at first, second grade, and takes them up through junior high and above. So Simon, you said the fourth dimension was time, and I can build into that. It takes a lot of time. If you have a child that is pre-cooperative, that's sort of a euphemism for not ready to sit still. So, yeah, that we say anxiety and fear. Behavior is the fourth dimension that I use, but I agree with Simon. And this is one of the main reasons that there's problems that the orthodontics profession, they don't have to have 1 second of demonstrate competence in behavior guidance. None. Because why? Not only do they not treat them at that young age, they shouldn't treat them. In fact, anyone who is treating them, it should be malpractice. I see it all the time. So this is something I learned to interpret my pedo behavior guidance training, the child development and child psychology. Our program director, chairman at Iowa in the 80s had a PhD in education and spent a lot of time, so I learned a lot about child development. But not until I studied cultural anthropology did I realize that these things that seem to be common sense, they're hardwired for imitating children and to assimilate adult culture. If you look at hunter-gatherers, that's one thing. There's lots of variety in all kinds of things that they do, except the way they look and the way their jaws are, craniofacial respiratory complex. But the way they raise their children, there isn't much variability at all. And it has to do something with natural selection. If you didn't raise your kid this way, they didn't get out of childhood, and they didn't survive long enough to become somebody who can survive long enough to pass on their genes. Okay, that's called evolutionary fitness. So, they're hardwired to assimilate adult culture as soon as possible. And they watch, and they imitate, and they learn. When you got a kid coming into your office, referred for sleep disordered breathing, has malocclusion, guess what? If that parent can understand, and usually I do all my tracings in front of the parent. I treat parents like residents, like dental students. I go over every single metric in pretty good detail, and they feel respected. And damn it, they want to know, and they want to be able to help their kid understand. It's like crossing the street. It's really important that you do this. I say, don't punish them for not doing it. Reward them, praise them for the behaviors that you want, and you will cultivate this. So, this is just a rendition, but, look at learning how to make tools. And somebody asked me for this.
He's been a 40-year veteran. He's one of the top financial advisors in the country. I have an
This is people, they're hunter-gatherers that sleep on their shoulders so bugs can't get in. You tell me that kid doesn't have to be still, and look at that lip seal, look at that nose, look at that posture, okay? So they sleep on the ground. They're called Khoisan, and they're in Africa, and they haven't changed. This was almost over 50 years ago, so lots has changed. But it's from a film called The Gods Must Be Crazy. And it's really interesting. It was one of the first things about hunter-gatherers.
All right.
So this is I call her a hunter-gatherer mom.
He told me,
okay?
this is your face, right?
This is just a DX. That is less radiation than a bite wing. Okay? So if you have someone timid, you can still get the airway and share it with an ENT.
So great, because look at the change.
So you think this little guy, and mom saw that, what she's conveying to that kid, do you think that kid's not going to do what she wants him to do? It doesn't. I don't have to manage his expectations. She's already done it, and she will do it. Okay, so gonial angle. I didn't hear, and I don't know if Peter Bouchang looks at this, but he looks at mandibular plane to SN or Frankfurt. This is a very valuable metric, and I've checked it on the Bolton norms. Okay, so you should be by 6 years old, you should be under 130 degrees, okay? Younger than 132, 131 in a 4 or 5 year old, it's high, but it does tend to, because of the malleability, and if you can change the habits and posture, you can actually change that angle. But it does correlate highly with risk for sleep disorder breathing. Okay, so measuring the gonial angle is not a difficult thing to do. Okay, this kid here, almost 150. But when I showed her photos to people, does that look like a vertically growing kid? And look at deep bite. And about 10 people that I'm on an online group with, name her. People said she was normodivergent to maybe even hypodivergent. And then I showed that. So this is another thing. If you have hypodivergence, if you have sagittal problems, you got transverse problems too. You do, okay? And lack of tongue. And put a nickel between each teeth by 5 years old, 5 and 5. That's something that goes back 100 years. And that's called the Bogue Index. And I do it on every single patient, and we monitor it. And when you do that, I mean, look at the sinuses, and look at the turbinates. So all right, who's from Atlanta? Somebody's from Atlanta. Okay, you're gonna probably we talked about this. This is a child I worked up who was referred to me by sleep medicine. Okay, and dad got relocated to Atlanta. That's why I put that. She's from Atlanta. Okay, so she's got anterior crossbite, and I put the Bolton on her because people were curious about it. So I'm going to, do you do the Bolton template? Do you put it on? So, and what's going on here? Okay, is that canine in a 4-year-old? Is that ever going to, come in non-ectopically? It'll come in ectopically if it comes in at all. A Panorex is for transverse only, we were taught. But I've seen thousands in my career, and I'm thinking sometimes you can pick up a vertical problem and maybe even a sagittal problem. That degree of crowding, you think that anterior crossbite may have something it's not just transverse, but if that maxilla is back, that premaxilla, and those teeth are developing in what Simon brought up, I never hear anyone talking about this, basal bone. Okay, basal bone is different. As it gets older, it's a little more compact. It's more condensed than alveolar bone, spongy bone, but it's all spongy bone. But when these teeth, these follicles are developing in basal bone is the reason that you get so much relapse when you start kids too late, because it has memory, and it's going to pull everything back over time unless you have rigid retention in there. That's like saying, I'll cure your diabetes, but you have to inject insulin for the rest of your life. But I'm going to cure you. That starts with a bull, has an S in the middle. It's just, you didn't cure anything. Well, if you start a kid late, and I fixed your malocclusion. When can I take out my retainer? Oh, your family will do it at your funeral. They'll take it in the casket, right? Because you'll be dead and you won't have relapse potential. Okay, so I'm thinking that possibly here too, like what's going on here? This doesn't look like, there's an antigonial notch there. Another thing you can tell, if these kids are shifting out of centric and going down the eminence, they're trying to breathe while they're holding their mouth still and looking straight ahead in a natural head position, Frankfurt horizontal. So I have all these records, and I thought, okay, I'm going to try, this is the, and I'm going to give this out to everybody. I mean, right? Because these guys, Darren Ward, orthodontist, Brian Hockel is a primary care general dentist in California who treats kids. But, does she look vertical to you? Does she look even, maxillary retrognathic? She looks bimax retrusive to me, but I don't think to most people she does, but my eyes have been trained. So anyway, I'll give this PowerPoint to anybody. But these standards are established. They were radiating 1-year-olds, even newborns. They had this new toy called a cephalostat. So anyway, but I've got the templates, and here she is. Her whole face is back, all right? But she doesn't look long there on her x-ray. It might be a different story. The other thing is the slope of the nose and a line tangent to the cheekbone, to the infra eyelid, they should be parallel, okay? They're not. They diverge. So that's another indication, it's a quick one, of maxillary retrusion. So look at that. Anyone argue with me? That's not vertical? Excuse me? And you don't want me to take an x-ray because she's only 4? 7 microsieverts? I'm sorry, I can defend that. And there, look at that, 141 degrees, right? So, and then facial height, I measured facial height, from nasion, anterior nasal spine, menton, lower facial height relative to total facial height should be about 55% at any age, and that's consistent with the Bolton norms and in the literature. That this is what we really want to get. We don't want an excessive lower facial height. So there we go. But I'm thinking, what do you think, Simon? I mean, sometimes you need a stuff to back it up, and I wouldn't make that the primary reason that I say that kid's vertical, but you might be able to pick up that on there. So here's what I got, and this is what I'm going to give this delightful person in Atlanta. And again, please take courses, but you don't have to take courses before you start treating your own kids or helping me. I can mentor you from Chicago. You will help me help this child. If I can't find somebody who really has a lot of experience, I would much rather have somebody. They want to fly back to Chicago because they don't have anybody, but I said I really need to find somebody and I can help train somebody, and they're good with it. So we'll see. I'm going to send you all this stuff, but I need you to email me, please, and I'll send all this to you. But look at that. This radiology report is so powerful. You think an ENT is going to not listen to you or a pediatrician? They might, but this, if you call and you send it to them, they got to put it in the electronic medical record. They go on record as known, yeah, Boyd told me about this, and here's a radiology report. All right? And what does that say? Tonsillar radio, oh my gosh, look at that. And what does that mean? High risk for obstructive sleep apnea. They better not just file that away. And if they don't want to refer to an ENT, I'm gonna, because I got a couple of them that they love me. And they know that I will work together, they will work with me, and we're going to help this kid. It's taken years. All you need is one. All you need is one pediatrician. All you need is one ENT. All you need is one allergist. That's all you need. It'll build from there. Trust me. So we have already seen that. Okay, the functional matrix theory. What is the function? Now, those of you who sat with me at dinner the other day or whatever, you're ineligible to answer this. According to Melvin Moss, Columbia in the 60s, what is the functional matrix of the masticatory complex, chewing hard food? A lot of people don't know that. I didn't know it. Nobody raised their hand. It's the food, that's the matrix. Okay? That's what we're adapted to throughout human and pre-human history. If we didn't demonstrate competence, masticatory competence, under the age of 6 years old, we were dead. We were goners. Okay? It just didn't happen. All right? And that's what led to Simon's good posture. Well, vigorous nasal breathing. Okay? That develops the functional matrix of the nasal-respiratory complex. The matrix itself. What is the matrix? I know you know it works. Bones have to be grown. They don't just grow. Like long bones, genetic. It's mostly genetic. You won't necessarily reach your 6'8" parent's height potential if you don't eat well and sleep well and exercise and get sunshine. But you're going to get close to it because of the genes. It's highly, genetic preponderance of not predisposition, but predetermined. All right, but this doesn't work that way. Anything above the clavicles, forget it. They have to be grown. What grows the cranium? What's the functional matrix of the cranial ball? The brain. What is the functional matrix of the eye socket? The growing and moving eyeball. Yeah, and he does. He talks about that. So, okay, here's the good stuff. Depending on if you like anthropology or not. It's almost 5 o'clock. Can I keep going? Do you want me to keep going? Is there a hook? Do they have a hook over there? Am I going to get pulled off the stage?
So it is 4:57. Another 10 minutes and then Q&A to wrap up. Is that okay?
Okay, so this is the big stuff. This is what I want. All right, these are the two clades. All right, hominin ancestor about 5-6 million years ago led to the chimp, and all these people led to us. And we're the only ones living. Now, why am I showing a car? All right, this is just a real quick, anthropology lesson. Toyota used to be a textile factory in Japan. They wanted to learn how to make cars. So they sent some of their engineers to Detroit, and they learned how to make cars. And that was their first car, the prototype. And it evolved because of environment. Like that was for city streets. That's for out in the jungle, okay? So that's a different environment. So that's just an example of how things can evolve from a simpler form to a more complex form because of environment, okay? So this here is a clade. This is a clade, and this is where the Neanderthals broke off, and this leads to us, and this is where Homo heidelbergensis was, okay? So I just love this. I stole it from that guy I saw on the first slide. What's this? Okay, I call that an anatomically modern Toyota. Okay, so that was just recent. So this is my slide that took 8 hours. Okay, it did. It took me 8 hours. Watch this. Okay, what happened there? That's brain growth. Okay, everything that I said earlier: tooth size, jaw size, facial size, muscular robusticity, gut length, all shrunk as our brains got bigger. What is the relationship? All right? Does anyone want to hazard a guess? You know how long? This was like a lightning strike. I've been looking at this stuff for 15 years, taking classes in anthropology, and it just hit me of why our brains got bigger. Okay? Reduced tooth size. Brain's getting bigger. Reduced dentition. It's happening. Gut size. Getting smaller. Eating meat. He said it. It's eating meat, protein, and it's not just meat, it's what else is in the animal. Marrow and fat. You bet. So rich energy. But do you know how long it took to chew raw meat? Okay, so there's a problem. Unless we as hunter-gatherers, we were scavengers, and then we became predators, okay? And we became predators. We had tools, we had arrows and javelins and things like that, but we didn't have fire. And they call fire in lava, like lava flows. People lived near lava flows like rivers. They were coming out of the ground. They weren't necessarily volcanoes. And this is conjecture, who knows, but something must have happened about 2 million years ago before mastery of fire. And there's some people in a given species that, like early Homo erectus, had a smaller brain than the ones that lived, 750,000 years later. Well, they discovered fire. They were cooking with fire. And that's an expensive organ. The brain is they call it the expensive tissue hypothesis, that there's things that require, every fourth breath you take right now is for your brain, okay? One, like every fourth meal, okay? That goes to feed your brain. That's why it's very expensive. Guts are expensive. Livers are expensive. Can't afford to shrink that. Kidneys are expensive. Can't afford to shrink them. Okay, so the gut shrunk, the teeth and muscles and all that. So the diet became more refined, a better diet, higher quality. We used to spend all of our time and energy while we were awake in pursuit of food and then chewing it and digesting it. And we had to poop it out before we could do it again. And our guts had to be really long because they had to process it too. Okay, so fire comes along, stone tools got better, and that's my revelation, you guys. If you take one thing, because now you can figure out the importance of myofunctional therapy and steering parents away from baby food and the importance of babies needing to chew. And I wanted to ask Simon is, if this isn't developed really well before the age of 6, can it ever fully develop? I mean, mewing, does that work? I mean, I just don't know. I think if those muscles weren't developed, I don't know, there's so many things that need to develop before the age of 6, or a kid is just left in the dust. So I don't know. I'd say maybe a rhetorical question there. You can talk to me later if you don't want to opine on it. Okay, so a lot of when does class 2 start? Okay, well, certainly at birth, in the deciduous dentition, but perhaps before birth. And this is in the literature for 100 years. There's so much that can happen in utero. And we see kids, like Guilleminot's thing with the inferior facial angle, it's back. And that doesn't go away, okay? So, and the reason I bring this up, and I got this from Simon, he doesn't know it, but I listened to him 10 years ago. Well, it's just like spectacles. That's what they call them in Australia. But if it's a child needs spectacles, it's like, oh, Simon, that's great. So I use this with almost everybody. So again, this is that from the Dunedin study where they said, yeah, deciduous dentition, it does persist, the malocclusion. But the good news about it is you can help parents and care get better prepared, to pay for inevitable orthodontics. So I think this is one of my last slides. It was at one time. But these are things that show that short stature and malocclusion in all three dimensions happens with kids who are born premature, especially very early premature birth. There's something called apnea of prematurity. But, and this is the facial height. These are the metrics that I use. And class 2 is something that is very common in preterm babies. And I put this in. Does everyone know Mariana? Take her course if you want to get good at this. And she opens her talk with, I'm not going to say anything about airway. I'm a periodontist. I'm going to talk to you about the advantages of expanding a child who's narrow early to encourage good axial loading and juicy bone, that the tooth comes in juicy bone, and that the mucogingival junction is healthy and it's more resistant to age-related periodontal disease. That's all she wrote. So thank you. So are we going to do a Q&A?
Yeah, let's wrap up with our final Q&A. Thank you, Dr. Boyd.
Yeah, thank you.